Hello, everybody, and welcome to today's launch of the Future of Sustainable Value-Based Care and Payment, Voluntary Best Practices to Advance Data Sharing, an actionable playbook for health insurance providers, ACOs, and other value-based care entities, and physicians and other healthcare professionals. Produced in collaboration with staff and members of AHIP, the American Medical Association, and the National Association of ACOs, with the assistance of the ARERA Health Group. I am Carol Vargo, Vice President of Physician Practice Sustainability at the AMA, and I will kick this off today before turning it over to my colleagues at AHIP and NAACOS. Before we begin what will be a 20-minute overview session, we want to remind you that this session will be recorded and will be available after the event. Following the presentation, there will be about 10 minutes for Q&A, and we already have had some great questions submitted, and we'll be taking them live during the presentation. So I think we'll have a robust discussion. Please submit your questions if you have not already using the Q&A box on your console. Please note that today's slides and the playbook itself are linked in the resources section that you will see on your console. So before we begin, we would ask that you would please read this disclaimer language for a moment on this slide. Please note that all proceedings related to this playbook were conducted in compliance with current antitrust policy and guidelines. And a bit about who we are for those who may be unfamiliar with our organizations. AHIP, the AMA, and NAACOS collectively represent health insurance providers, physicians, and medical students across the country, as well as ACOs across the country. Our presenters today joining me will be Danielle Lloyd, Senior Vice President for Private Market Innovations and Quality Innovations at AHIP, and Aisha Pittman, Senior Vice President, Government Affairs at NAACOS. So let's dive into our playbook. As you can see here, we have been very strategic in the approach that we've been trying and intentional in approach to this effort that we're embarking upon and sharing with you today. Because with more than a decade of experience implementing VBC and payment arrangements that have really intentionally been designed to promote positive patient outcomes, AHIP, AMA, and NAACOS have assembled a diverse group of physicians, ACO and payer voices from across the country, each with a wide array of experience in these arrangements. We've really tried to work to identify and assess which industry-leading best practices show the most promise in sparking meaningful advances. Representing three pillars of our health system, it is our hope that this unprecedented cross-industry effort can translate into tangible industry-leading practices informed by real-world experiences that our nation's healthcare leaders can directly apply to build our own success with VBC and payment arrangements. Importantly, these best practices are applicable to a broad audience with a wide range of experience with VBC, including those already offering or active in arrangements and those who are seeking to participate in the future. This is a multi-phase effort, and we are sharing with you today the results of phase one, data sharing. As we are all aware, the move to VBC delivery and payment has been and continues to be quite complex, ever-growing complexity. Our effort began with data sharing best practices because all three organizations, as well as our members, agreed that access to timely, actionable, and accurate data is core to the success of these arrangements. So now I'm going to turn it over to Danielle Lloyd, who's going to start by highlighting some of the key themes and best practices in the playbook. Danielle, please take it away.
Thanks so much, Carol. So if you could bring up the common themes, I want to start by sharing the cross-cutting issues that surfaced as we were building these best practices because these issues and these themes can influence the willingness of participants to share data, and it can also influence the readiness of these organizations to ingest the data, act on the data to improve quality, equity, and affordability. And so these issues need to be considered within the value-based programs to ensure that they're applicable across different settings. So the first is around data privacy. As we share more data across more types of organizations, we have to be really vigilant around the potential impacts on security as well as patient privacy. Second, the lack of mature data standards can really be a barrier across various use cases of the data because there are going to be differing requirements and processes, and that's less efficient. Third is variability in the data infrastructure. And so this means that the capabilities to share can vary by, for example, region. Some regions have access to robust health information exchanges, some don't. Fourth is around participant readiness. Both the plans and the providers have different levels of experience and capabilities. It's not something, none of this playbook can't be a one size fits all. We talk about alignment, but not uniformity. You have to meet the different participants where they are. As an example, some physician specialties don't have as ready access to certified electronic medical records, as an example. And we actually include a maturity model in this paper to think about how do we incrementally implement some of these best practices. Fifth is around federal requirements. Certainly it came out throughout around CMS requirements, ONC requirements, other organizations, the readiness of the infrastructure standards like national directories, so that would play in. And then also around financial investment and participation in these programs does require an investment, an upfront investment, to the extent that these programs are not aligned across organizations that can increase costs. And then, making sure that we're recognizing upfront investment in the value-based programs is going to be key to scaling. So if we go ahead and move to the voluntary best practices for data sharing, there are, sort of 5 overarching categories of best practices around the interoperability of the data, the need for comprehensive data, information to reduce disparities, data that is timely and actionable, and how do we ensure that we have transparent methods. So let's dig in to these, and I'm going to start with creating an interoperable data ecosystem. So to be successful in these models, you have to be speaking the same language, right? And the systems have to be able to interface, whether it's physicians or hospitals or health insurance providers, we have to be able to ingest and understand that information. So there's sort of steps along the way here in terms of being able to sort of pitch the data, catch the data, be able to analyze it, be able to act on it, right? And so in terms of some best practices here, the notion of supporting content standards was an important piece. So how do we make sure that we're using standardized data elements and standardized data sets? There's also a need for use of exchange standards. So how do you get the information from one place to another? And that's not just about the standards itself, but also about things like implementation guides that are kind of the meat about, how exactly do you do that, and data maps, and really digging into the detail that maybe not all of us here on the call want to do. But there's a challenge because not all of these are sufficiently mature. Just to give an example of some issues there is aggregating data across different electronic health records and electronic medical records within an ACO can be difficult. So we do include in the report references and resources to various standards and operating rules that we think are helpful for different organizations. Another key piece here is around networks. So in some cases, how do we leverage what's already there in terms of sort of the pipes that are already there to share the data, that data use agreements might already exist, trying not to reinvent the wheel, minimize costs and burden. And that's where we think, this is sort of getting into this is best and promising practices. We're not quite there yet in terms of national networks and trust frameworks, but we're certainly watching what's happening with, for example, the TEFCA, the Trusted Exchange Framework and Common Agreement from ONC, and the California Data Exchange Framework. So that's some examples there. Let's give some examples on the sharing more complete and comprehensive data. So, in this case, we want to make sure that we're empowering participants with complete data, accurate data, consistent data, right? That provides a comprehensive view, paints a comprehensive picture to be effective and efficient around coordinating care, improving care, enabling more equitable care, et cetera. And so part of this is around how do we get and share among the participants, not just claims data, but other types of data. Certainly clinical data, we're in the process of finding ways to do that better. But even beyond that, so for example, public health data, we really all saw during the pandemic that the lack of integration between public health data, clinical data, administrative data was really something that got in the way of our collective work. So for example, health insurance providers did not always have access to information on who was insured if we didn't get a claim, right? But that really, makes it more difficult, made it more difficult for our members to help get people more vaccinations. So how do we get more and different types of data? And then also, how do we make sure that we're sharing data that's both at an individual level and a population level? And that depends on the maturity of the organization. Is it a big raw claims information, or is it something more refined? And just one thing that I'll say is a challenge here that came up as we went through this is patient matching. So the ability to make sure that the data a health insurance provider has, or a physician has, or a facility has, right, that we are sharing the right data with the right organizations and in a timely fashion. So let's move to the third one, improving data collection and use to advance health equity. In this case, we believe, as a best practice, we need to be collecting collectively and sharing data that can be used to identify and address a key point, right? Key piece there. We don't just want the data, but we want to be able to act on it to reduce health disparities and social determinants of health or health-related social needs, and really going beyond the clinical setting. But to do this, we certainly are mindful, back to those common themes about being transparent, using it appropriately, keeping it confidential, et cetera. So as we do this, there are going to be new challenges as we connect to different organizations like community benefit organizations or national registries. Those organizations maybe aren't using the same standards, maybe aren't using the same definition. And so, how do we work on improving those connections? And certainly one of the challenges is that right now, we don't all have demographic data on the patients and enrollees that we serve. So things like race, ethnicity, sexual orientation, gender identity, disability status, et cetera, that information is really needed and needed to be collected in a standardized way so that we can stratify measures to identify disparities. We can, look at measures of equity, et cetera. So there's a lot of work again in the standards area of trying to use standardized data elements like ICD-10 Z codes, and of course we're about to move to ICD-11, so it's always keeping us on our toes. But also thinking about how we can do trainings and support so that it's easier to collect and measure and analyze. And through all of this, making sure that we're really transparent with the consumers. So I'm going to go ahead and hand it off to Aisha for the rest of the best practices.
Thanks, Danielle. So on our fourth area, sharing timely, relevant, and actionable data, this really gets to the point that we have to present information in a way that can be leveraged to help make decisions. So data that is going to support clinical decision-making needs to be available at the point of care. In terms of timeliness, we also talk a bit about how frequency of updates. For example, one of the challenges is getting adequate attribution data and wanting to see that be done frequently. Some of the things to consider within having timely, relevant, and actionable data is the formats in which the data are shared. And one of the best practices is to be nimble and meet the varying needs of participants and accept varying formats and use varying formats. So, for example, we know some value-based care entities would like to receive raw data because they have the in-house capabilities to process and analyze that data, while others want to have more of a focus on having dashboards available to them and not wanting to have to process that data. Along the lines of considering the varying needs of participants, also thinking about things like supplemental technology. And if you're using supplemental technology, how are you supporting the practices in these entities with training and understanding how to use the data, or offsetting the cost to implement new technologies? A lot of consideration should also be given to how you leverage existing data sharing networks like health information exchanges or the automated admission, discharge, and transfer feeds to support some of that real-time information. Our fifth and sort of final area is around sharing data methodologies, calculations, and context. So ultimately, any successful partnership is going to rely on building trust. And this element really gets to providing transparency in all aspects of the VBC arrangement. So, for example, with benchmarks, wanting to have those established ahead of the performance period, having performance data shared regularly, having feedback loops to address any issues. If anything, calculations have to be done retrospectively, providing clear information on those calculations and data inputs for any retrospective adjustments. Also, one thing in this area that we really think about is, what do you do when complete information cannot be shared? So for example, there may be restrictions on sharing a health insurer sharing with the value-based care entity payment rates for services that are outside of that value-based care entity. So thinking about what type of information you can provide in lieu of giving that information, whether it's aggregate information or some contextual comparisons, to help promote and build that transparency and ultimately trust. So that summarizes sort of the five areas of the best practices. As Carol mentioned, we really see this as a guide to help folks who are entering into these value arrangements. In addition to best practices, we try in the playbook to talk about industry challenges and considerations, some of the government-led or public-private interoperability standardization efforts. And then throughout the book, we have highlights of the payers and practices of data sharing and action to give you real-life examples. This is just our first step. We will have coming soon another playbook that is going to focus on payment methodology. So stay tuned for that. And then I just want to wrap with thanking all of our work group members who are members of our various associations that participated in many discussions to help provide the real life examples and discuss all of the challenges, issues, and best practices. So thank you to all of those folks listed here on this screen. And with that, I will pass it over to Carol for Q&A.
Thanks, Aisha. We're only 1 minute over. So good. I have a couple questions that came into the chat and that were submitted earlier. So let's kick it off. And I'm going to throw this first one to you, Aisha. Good question. Has the recent turbulence in hospital provider finances accelerated adoption of risk-based contracting?
I will say yes. So it's not even just turbulence in hospital payment, it's across all providers. The turbulence in payment is leading folks to look at value arrangements as a way to stabilize payments. That is one thing that we saw occur during the pandemic, that we saw more providers moving to capitated arrangements, which is one of these types of value arrangements. So with the increase in that, we recognize that there is a need to highlight best practices and move to more standardization where possible. And so that's part of what we're trying to do in this playbook.
Those are good points. I would add from the physician practice perspective, I think, as you noted, during COVID and coming out of COVID, practices have been severely depleted. And I think many of those practices are feeling interest and being approached around entering these kinds of arrangements, but they don't really have the capacity or the infrastructure to do so, which I think has led them to acquisition. So I think this is really important, what we're trying to do to shore up practices to be capable of entering these arrangements, because what we've seen is a lot of new entrants into the market, acquiring practices that aren't necessarily even interested in value, some of these corporate entities. And I think our goal is to really ensure that physician practices are able to participate, are able to stay independent if they want, are able to participate in networks, because I think some of the consolidation issues that we're seeing are troublesome. So that's the perspective from, oh, go ahead. Do you want to weigh in?
I'll just add in to, say that, we agree that, there's a additional sparked interest in risk-based arrangements post-pandemic. And certainly, we agree that we're concerned about watching for further market consolidation. But I think that's really, as you were saying, Carol, part of the importance of value-based arrangements is that it can provide some stability. And, we've seen that clinically integrated networks, for example, can be very successful in total cost of care models. It's not necessarily about ownership structure and changing ownership structure. And so we're looking forward to seeing how this might have increased in the past couple of years. We actually will be having the results of the Healthcare Payment Learning and Action Network Alternative Payment Model survey released October 30th. We work on, AHIP works on that survey with the LAN. And so we are hoping to see an uptick there in the adoption of the risk-based arrangements.
Great. Here's another question. Let's do this one. Danielle, I'm going to give this one to you. Can you give examples of how we are applying lessons learned and trying to make more coordinated approach when it comes to social determinants of health data?
Yeah, sure. Thanks, Carol. So, one of the things we didn't talk about very much in our synopsis is that the report does use several lenses across the best practices. So things that are, similarly to the cross-cutting themes, things that we overtly wanted to think about. So, for example, new technology, that a lot has changed since we started down this road on, what's available. But, thinking about equity, so I'll use this sort of more broadly, was a specific lens. And that's to some extent why you saw there's a specific best practice around equity and social determinants health and addressing health-related social needs. But I will say that this work, this collaboration between the three organizations is not our only work together. So for example, these three organizations also participate in the Core Quality Measure Collaborative. It's a public-private partnership seeking to align measures across different payers. And in that, we're looking to, prioritize measures for clinical measures for stratification by things like demographic data, and also looking at converting some of the measures to digital measures so that they're easier to collect. So these things sort of all interrelate of, again, how do we make sure we have the data, but then also how do we make sure we can act on it? And I will say, the LAN APM model adoption survey we just talked about, that does include questions around equity and highlights how the health insurance providers are incenting different types of work within their value-based programs, whether it's collecting the race, ethnicity, and other data, whether it's collecting screening measures on social determinants of health data, how you're closing referrals, et cetera. And AHIP itself is doing a lot of work around modernizing demographic data, creating more granular options in that respect, and hopefully moving to some building some national standards in that area. So you guys tell me if I missed anything key there.
I think you hit it. Aisha, if you didn't have anything else to add there, I have another question for you in particular. How much do varying EMR systems and standards get in the way of data submission and sharing? What are some strategies ACOs have taken to overcome this and align data across their downstream participating practices and their vendor contracts?
Yeah, this is an area where there's still some challenges ahead. I think in terms of pulling in data from various EMRs is still a challenge that ACOs are facing. And they're, right now in a space of creating workarounds using third-party applications to combine data where feasible. This is an area where we see more work needs to be done from a standards perspective to better align the data elements so that they can be more readily and easily combined.
Great. This one came in, and I think I'll take it. What do you think is needed to get more physician practices, to participate in VBC arrangements? So that is a question we get all the time. At the AMA, our qualitative data, as well as our ongoing engagement with all of our members, really has highlighted three key things. First, physicians need the infrastructure to be able to participate in these arrangements. And I think what we're talking about today in terms of the data analytics is key to that. So aligning around that, I think, will go a long way to help physicians start to think about how to get onto that on-ramp if they're not already on that on-ramp. The second key thing that we have heard from our research with RAND, even prior to the pandemic, as well as all of our feedback from physicians on the ground, is they really need that stable and transparent payment. This has been something that's been ongoing in terms of continued erosion in payment rates. We also know and have heard that even physicians in VBC arrangements on the ground didn't have a lot of sense into transparency about how those arrangements were being developed, or even having any of that savings come back to them. So I think this is something that we're going to be continuing to work on. And I think that next phase that we're doing in our work here, addressing payments, really going to tackle some of those issues. And then I think the third key element is truly reduction in administrative burden in practicing and participating in these arrangements. If you think about it, an individual physician practice probably has 10 plus individual healthcare payers and contracts, and they're all different. And I think aligning around that and aligning around some of these key attributes, like what this AHIP NAACOS AMA activity is geared towards doing is really going to help, at least that's our hope, help further this with physicians. I think all physicians want to participate. I think that there just needs to be that on-ramp and that line of sight for them to see that this is the way forward, and removing some of those barriers to getting them to adopt. I don't know if any of my colleagues have any thoughts on that as well.
You know, I think just to kind of wrap that up, right, is that that's what this whole effort is about, is how do we scale value-based care and payment arrangements. And this playbook from our expectations, right, is essentially a cheat sheet to help advance participation more quickly and make it more effective at improving quality, equity of care, affordability of care, and patient experience, but doing that in a way that's also at the same time reducing burden for the participants.
Yeah, and one final comment, and I know we're over time. I do think the best practices and learning from their peers is crucial and paramount to those in the field. So I think the highlight of the best practices and that are done by actual players on the ground in this playbook are what's really the gold, as far as I'm concerned. So we did run short on time. We have other questions. We're getting questions about, you know, can we follow up? Please see here our various media contacts. And if there was a question you submitted or a question you have based on the content presented today, please follow up with these individuals. And with that, I think I'm ready to close. I just want to thank everybody for their time. I really want to thank everyone, including my co-presenters here. I think this has been a great endeavor, and I know everyone who's dialed in super busy at a super time. So thanks so much.
Great, thank you.